Hello, and welcome to everyone who's here live and everyone who's watching this on replay. My name is Mindy Levine. I'm the donor coordinator here at the Center for Trauma and Embodiment, which we say CFTE for short as well. Every 2 to 3 months, we host a roundtable discussion where we bring together folks from around the world to be in conversation. And I am super excited for today's discussion about the intersection between chronic health conditions and untreated trauma. A few things before I pass this over to Dave Emerson and Dr. Hazley. We're going to leave some time at the end for some questions, so please feel free to put the questions in the chat. I'll be in there during the next hour. If we weren't able to get to your questions, please feel free to email me. I'll put it in the chat and I'll say it out loud as well. My email is mlevine, Levine, @jori.org. So often a person's body is left out of the conversation when it comes to healing. And as a nonprofit, we have found in the past 20 years of doing research and work around the world that an embodied approach makes healing possible. If you'd like to support our mission, if you'd like to collaborate with us in some way, we'd be so grateful, and I'd love to talk with you further. I'll be in the chat for the next hour. So I'm going to hand this over to Dave Emerson and Dr. Desmonette Hazly, and welcome again to CFTE's Roundtable discussion.
Great. Welcome, everybody. Thanks for joining us today. We thought we'd try something a little bit different today, which is to invite you all into a conversation that Dr. Hazley and I have been having for the past couple of years. And with that, you're welcome to use the chat throughout the whole process at any time you like. Maybe there's a comment or a question that comes up to you as we start to unfold and evolve the conversation. Feel free to jump into the chat at any point, and we'll try to keep an eye on it, as Mindy said, and also reserve time at the end for that piece of the conversation. So again, my name is Dave Emerson. I'm the co-founder and co-director of the Center for Trauma and Embodiment. And Dr. Hazley, Desmonette, and I have been in this conversation for the past 2 years. And as we've evolved through this process, we thought it would be interesting to invite folks in to our process. So with that, I'll turn it over to Desmonette and invite you to introduce yourself a little bit and maybe talk a little bit about the work you're doing now as a way for us to get started.
Thank you, Dave. Good morning, everyone. I am located in Los Angeles, and I am, my background is in medical social work. I'm an integrative health specialist, which means I look at health from mind, body, and spirit, because everything's connected, and we basically work from all those aspects for a person as a whole person. I serve mainly underserved communities throughout Southern California, which includes South Los Angeles, Watts, Compton, East LA, Boyle Heights, all of the locations where there's underserved communities that are facing multiple socioeconomic challenges. One of the biggest issues of my work is providing mental health supports for these communities, because mental health services is seen in a very negative light for 2 reasons. Number one, there's a stigma attached to being labeled as someone needing mental health services, because as soon as you suggest mental health supports, the first response usually is, I'm not crazy. I don't need any help. I'm just stressed out. And the second thing is there's a history of utilizing mental health status as a form of oppression. It's been weaponized. If someone is diagnosed with diabetes, there's usually not a fear of losing your children or losing your job. If someone has a diagnosis of depression, PTSD, anxiety, they will keep that hidden, because it's very easy for someone in a position of power to use that against them. People have lost their jobs. Mothers have lost custody of their children because they were seeing a therapist. things of that nature make people not want to seek mental health supports. And in my work, your mental health status or your mental health, I want to say capabilities or stability will impact your health. There's a direct connection between your mental health and your physical health. So in order for me to do my work without having the stigma of mental health, I utilize lifestyle and mind-body medicine. I don't know if any of you have ever heard of those modalities in healthcare, but lifestyle and mind-body medicine, those are two different modalities. Mind-body medicine is the evidence-based research that your mental health is directly connected to your, not only just your general health, but also is usually the contributor to the major and common chronic illnesses. If you have depression, if you have anxiety, if you have a lot of things going on with your complex trauma, it's very likely you're going to have at least one, if not more than one, form of chronic illnesses. Lifestyle medicine provides the tools to address the mind-body connection, not just diet or exercise, but things like medical arts and humanities, prescriptive exercise and movement, like dance. All of these things can provide tools for the community to actually address their chronic illnesses and mental health without stigma. So that's the avenue I took so I could better serve my communities that I work with, because it was a losing battle to offer mental health services because people rejected it because they were afraid of what the consequences could be for them.
Yeah, and this is, you know, this is the wheels are turning now in terms of our conversation, right, as it's unfolded. Our organization, interestingly, because I'm personally not a clinician, but I think our legacy is very clinical, very academic in a lot of ways, coming out of the trauma center where we're located at first, for example. The perspectives, kind of the unexamined perspective for us was to kind of lean heavily into trauma care, right? And I think that language was, we were oriented toward being trauma care experts. So as you and I have started to talk about that being, particularly that word, being an immediate, almost a signal, right? That this is not a safe place for me. Because, and here's maybe where I'm curious if you want to talk more about that identity, right? The identification that seems to be required. I am a trauma survivor, as opposed to something else, right? And so what is that something else? You know, as opposed to having to identify as a trauma survivor to get access to, let's say, services like this, what are other possibilities there in your mind?
It's all about the language you choose to present the services that you provide. So I have trained myself not to use trauma or traumatized or mental health services. This is how I would basically, someone coming to me, or actually a doctor who will recommend a patient who has been taking their medication, been doing everything they needed to do to manage their diabetes, but they're in a home where there's domestic violence. And the patient will not talk about the events in the house. She will just present as saying, I'm very stressed out, and has rejected seeing a therapist. So a physician will send them to me and say, what can you provide for this person? Because she's not going to see a therapist. So I will introduce myself as Dr. Desmonette Hazly, and I'm an integrative health specialist. And I'm here to assist you with your control of your diabetes and using stressed out. And that is my code word for trauma for this person. I'm going to use their language. So they're telling me they're stressed out because they have a lot going on at home. So, and I say, I'm going to work with you so we can get your diabetes under control, and let's see what we can do about the stress you're having. Can you tell me what's going on? And they'll talk about things that have gone on. And I said, you know what? That could be a very traumatic experience. I'm not labeling the person. I'm labeling the experience. So I'm not associating them with as a traumatic person. I'm connecting the traumatic experience with the events. And I said, that can possibly be causing you to have all this stress and the inability of managing your diabetes. All the person is hearing is, I want to get my diabetes under control. And I say, in order to do that, we might want to help you with your stress. They're seeing the stress / trauma as a tool to manage their diabetes.
Yeah.
As I'm seeing them and they're coming to me regularly, and I'll say, you know, sometimes when we're very stressed out and have had traumatic experiences in our lives, you can have insomnia, you can have things like feeling hopeless and helpless, bits or bouts of crying. And they're like, yeah, that has happened to me. And I said, you know, there's a name for those things when you've gone through a lot of traumatic experiences. It's called trauma. You may be feeling a bit possibly traumatized, but those words don't come until maybe a month or two that I'm seeing them.
Yeah, you used the language, you said code word at the beginning. I think that's really interesting. Like you're picking up their way of describing their experience and starting there,
Yes.
as opposed to saying,
yes,
requiring somebody to identify
yes,
your way, let's say, or my way, in order to get access, right? So like, to me, that's a really important shift. And then you can have the conversation. So
yes,
the other thing I'm wondering about too, right, is the understanding on, here's a question. In your work, right, and in our conversations, the awareness that traumatic experiences can correlate to impacts on health, like diabetes, let's say,
yes,
that's there, right, for you. But for the person seeking care, they're not, the value isn't necessarily, I need to manage my traumatic experiences. I need to manage this diabetes.
yes. That's their first concern. And I go where the patient is, and that's pretty much where they are. They are taking medications, they're trying to manage this chronic illness, and they're more likely to see their physician than to seek out a therapist to deal with whatever's going on with them mentally. They see mental health services as just an optional supplemental service, something they don't have. It's just something that's a side. If they want to do it, they don't see it as part of the overall treatment of their conditions. And I take a lot of time making the connection between mind, body, medicine for them, so they know. And one of the patients, I said, okay, tell me when you have the most issues with your high blood pressure. Says you're taking your medication, you're doing it, so tell me what's going on. Oh, my son's having trouble in school. He got kicked out because he was carrying a gun. So I'm saying, so what happened with this? What happened with your body? My blood pressure went up. And I say, do you see a kind of a connection, something very drastic and very stressful happened? And even though you took your medication, your blood pressure went up? She says, yeah. And I asked, does that happen all the time? She says, yes, because there's a lot of things happening in my life. And I said, well, that's where whatever's happening in your life that's affecting you mentally is going to affect your health. We have to work on that. And my question is this, I want to help you get better. Are you open to using some tools to getting better? Because if I don't want them to run away from me just because I use words that make them fearful, that I'm going to label them as crazy, mentally unfit, because that's used a lot for a lot of people in underserved communities when people want to deny them something. Oh, they're mentally unfit for this because they're seeing a therapist for this particular issue. And it may just be because of depression, just simple depression. But because you're seeing a therapist for mental health reasons, it is assumed that you are unstable and are unfit and cannot manage normal circumstances.
Yeah.
And that makes people run away from mental health services. And I'm constantly trying to have a balance with that. And it's using the language that a person's most comfortable with, and then introducing traumatization and those type of complex trauma later on. That works because you have to make sure the person feels safe with you. They don't want another label. You had shared about the YWCA or YMCA in Massachusetts. They had this whole trauma program and nobody showed up because they called it a trauma program.
Yeah.
Would you like to share that?
Yeah, absolutely. Very interesting. So here in Massachusetts, where I'm located, where I live, there's a consortium of about 7 YMCAs north of Boston. And I was contacted by somebody whose job is to sort of manage mental health care services for everybody that uses the Y, including staff. It's pretty, so he's there, which is great, right? Like, so there's this really innovative thinking around what health is that includes mental health. But so he reached out to us because we do, embodied mental health care, weightlifting, and yoga, which are already happening at a place like the Y. And so his thought is, well, let's bring in, this trauma-informed approach so we can actually manage to offer people mental health care. And we can talk a little bit more about how we're, together, and all of us probably here, we're expanding that concept a little bit here, as well as the physical health care. But one of the things he said was, we tried offering yoga for trauma or something for, and people just didn't come. And that just really resonated with the conversation we've been having. And it's, I'm thinking too about, so we have this way of showing up for people that doesn't require them to identify as a trauma survivor to get access to what we have to offer, let's say. How about from the system side? Let's take the healthcare system side, in your experience with like physicians and doctors. What's your experience with their, maybe this is I don't know if this is too broad of a question, but is there an awareness, would you say, in the field, or how has this changed over the years around this connection between mental health and physical health? Or how do you see that?
Okay. In the general sense of health care and mental health services, everybody stays in their own lane, in their own silos. And I can give you an example. So a doctor will recommend that a person seeks mental health services because they're non-compliant. And that's the word they use, because the doctor will say, I'm doing everything to help them. I'm giving them the medication. I told them about their diet. I told them about exercising. They say they're doing everything they're supposed to do, but everything is exactly the same as it's been for the past 3 months, no changes. So I think they're being very defiant with my recommendations and being non-compliant. The social worker or therapist says the person won't come see me because they feel that they don't need mental health, and see what you can do for them. Person sits down with me. What's going on in your life? I says, have you been taking your medicine? Have you been whatever? And they said, yeah. And then they'll start telling me I was evicted with my 4 kids. We're living in our car. I possibly can. I'm taking my meds. I'm eating as healthy as possible, but I can't seem to feel like I can take care of myself because every day I'm struggling with living in the car. I'm taking my meds. I'm eating what I can. I can't seem to make it all work for me. The person's not being non-compliant. Person's traumatized, got kicked out. She's with 4 kids living in a car. No matter what she does in regards to trying to help her condition, it's not going to work because she's going through traumatic experiences. The doctors and the nurses or whomever she's working with for that condition had to be educated to let them know about interoception. If a person is traumatized, having has PTSD or complex trauma, their interoception is actually off, is not working correctly. So sometimes they're not going to know when they need to take additional medication if their blood sugar is going low or if their blood pressure is going high. All of these things are being impacted by trauma, and the doctors and the other medical staff is seeing the non-response of what their treatment is as non-compliant, and they're blaming the patient.
Yeah.
I do a lot of work.
Yeah.
Yeah, go ahead.
No,
I do
go.
a lot of work educating the doctors and the nurse and medical staff in general, because they're only looking at the physical treatment of a person and not taking in consideration the mental contributions of the outcome of the treatment. There's no connection. So I have to actually go to multiple disciplinary team meetings and explain this to doctors and bring all the research and make packets for them, because this is not discussed with physicians or medical staff. All they see is, okay, I gave them the medicine, I told them what to do, and they say they did it, but why are they coming back with everything exactly the same?
Right.
So it's a lot, because I think we have been trained as in our profession, stay in your lane. A physician is not going to say, oh, I need to learn more about mental health. They're not thinking that way because we're not trained even in schools to actually think outside of our professions. And that's a struggle, because I'm educating the patients while I'm educating their physical health professionals, so they can meet in the middle and actually work together.
Yeah. I mean, you identified yourself as an integrative health specialist at the start, and so it sounds like one option here for us, let's say as a community, is there's somebody like you that's the glue, right? Let's say that's bringing together these different stakeholders, kind of breaking the walls of the silo a little bit, inviting people in. Do you think, is that the only option? Is it productive? Do physicians have an incentive, let's say, just on this topic, to listen and to kind of like,
yes, they do, but it's all about them and not the patient.
Yeah.
Because there are certain benchmarks they have to meet in regards to ratings of their services. And so what I say to them, if you want the outcomes to be positive and to show that your treatments are working so you can meet your standards of care, because that's what they're looking at, meeting their standards of care. When something doesn't work, and after they've done their treatment, it reflects on their level of standard of care. So my stake or my angle that I use with physicians and medical staff, to meet your standard of care requirements of positive outcomes with your patients, you're going to have to consider their mental health, because it's impacting your treatment outcomes. If you want your patients to do better with your treatments, you're going to have to incorporate mental health supports. They hear that because it's about them. It's about their bottom line. And unfortunately, I have to go there with them because my job, whatever angle or whatever avenue I can take to get them to understand that there's something beyond what they know in regards to physical health that needs to be incorporated, I basically use the language or the perspective that speaks to them. It's like I have to speak different languages to different people.
Yeah.
So when I'm with the physicians, I'm talking about standard of care and outcomes of treatment. Their concern is what I'm doing going to make the patient better so I can report this for the statistics of the hospital?
Mm-hmm. Mm-hmm.
That matters to them. So it's about we care about trauma patients from the patient point of view. And I think everybody who's here at the roundtable, we're always thinking about the individual patient. When you're looking at large systems like healthcare, departments of mental health, all of these, they have agendas and objectives they're trying to meet. The patient or client is always secondary or tertiary, unfortunately. We as service providers, we are the human side of that, doing, I don't want to use the word doing battle, but we are kind of doing battle with systems. Systems are impersonal.
Mm-hmm.
It's like all they care about are outcomes. They're not looking at the individual.
Mm-hmm.
In order for anyone to basically be able to advocate for a person, you have to understand the system and what they will hear when you talk to them. So that's the thing with healthcare and mental health services and all of these other, even what is it, like the judicial system, when you're dealing with someone who's been traumatized and they have PTSD and they seem uncooperative and don't want to testify, or when they don't make a good witness because they can't present what happened to them. They don't understand that there's mental stress and trauma going on with that person, and they can't give you what you're looking for because they have a lot going on. It's not like they're not cooperating with you so you can do what you do as an attorney or a legal advocate. You have to look at what's going on with them mentally and find out how to support them so they can give you what you need so you can help them in the judicial system.
Mm-hmm.
It's the quantitative, like statistical stuff that people in systems want, and we are the qualitative. We're the specific people.
Right.
We are the people who get to know the person as an individual and want to support that person. There has to be a meeting in between for all of it to work. But because we are not interdisciplinary in our approaches, because we have been taught to stay in our lane.
Mm-hmm. Yeah. The kind of the overlay of
so that's yeah. So it's for all of us who are advocating for the individual, we're constantly trying to find the words and the avenues to use to make people understand what's happening to the people that we're serving so we can better serve those people. And we would love to think that, oh, all I have to do is say this person is suffering. They don't hear that. They're thinking about what their perspective of what they do. So how do I get a lawyer, a doctor, a medical a therapist to understand the person that we're all on the same team. The person we're trying to help is going through these particular issues and it's impacting their mental health and their capacity to help us help them.
Mm-hmm.
You have to basically deliver a different message for each person, and it gets tiring, but you have to deliver the message.
Right, for the effectiveness. And I'm really that the whole concept of code words is something that's really sticking with me today. Like you talked about the code word around stress. So when we're talking to a person, right, let's say a client, a a person from our perspective that we're providing care to, learning some code words. And then when
Yes.
we're dealing with systems, then we have some code words now like non-compliant, right? That's a
Yes.
code word in a sense. And in the psychological world, there's treatment-resistant PTSD. That's a code word too, right? It's like
Yes.
we do have to be code breakers in a certain sense.
Yes.
We're engaging in this kind of
Yeah.
work.
It is.
Yeah. Do you
Go
want to
ahead.
talk a little bit about, recently, one of the things that's come up for us lately is there are a couple of systems, right? Like, I think it's the Mayo Clinic that we were talking about recently. It's starting to do some, or maybe they've been doing for a little while. People are coming in for health issues, but
Yeah.
they're building language into that intake process, right? That sort of
Yes.
offers inroads. Do you want to talk a little bit about that, just as an example?
Yes. Thank you for bringing that up. So the Mayo Clinic has been designated as the best hospital or healthcare facility in the world, hands down. One of the reasons why their services are so effective is because finally get that you have to offer mental health services along with physical health services at the same time. They're not separate, they're at the same time. So if, an example, if you're going in for pain management or for cardiovascular management of symptoms like high blood pressure, you're going to see a doctor who's going to do an intake on you and basically ask about your physical symptoms, and then ask them, say, so tell me what's going on in your life, anything going on at home, anything with the job. Doctors never ask those questions because usually they don't care. They want to know just give me the facts about your body. That's all I
Simple.
need to know.
Yeah.
Mayo Clinic, you get to see an intake person. They'll take all your information. Then your treatment plan will include pain management from the physical health point of view, but you will get patient support, which is the mental health services. They don't call it mental health services. It's patient support to help you manage stressors in your life so you have a better outcome for your pain management or your high blood pressure or your heart disease. They figured out the code switching.
Yeah.
Because they understood a while back that, oh, we need to offer mental health services. Everybody rejected that. But what they found was everybody who was coming in for high blood pressure and pain management had issues with stress and or experienced a traumatic event.
Yeah. Yeah.
And that was the thing. How do you get people to accept care that's beyond the physical so they don't have the stigma of mental health support or services? They say, this is patient support. Here you go. So we're going to help you with your diet. We're going to help you with your exercise. And then we're going to have someone contact you every week so you can talk to them and tell them what's going on in your life. And guess who that person is? That's a therapist. They're not called therapists. They're called patient support staff.
Yeah.
Everybody's getting what they need.
Yeah.
No one's feeling labeled or stigmatized, and the patient's outcome are absolutely wonderful because it's all inclusive and comprehensive: mental health, physical health, and it's being brought to them by a team who understands how it all works together.
Yeah. Yeah, that's amazing. And it's sort of an example, right, of what we can point ourselves towards as a community here. And I'm assuming that that's also outcome driven, let's say for the Mayo Clinic, because they're considered the best healthcare center or hospital in the world. That's outcomes, I'm sure.
Yes.
Right. And this is, I'm sure they're seeing data.
Yes, exactly.
That's this approach to outcomes.
Exactly.
Yeah, I think, for us, right, as a community, it's a big shift. I don't know if everybody relates to it that way. And folks, feel free to chime in any way you like in the chat. But that shift from the idea that we have something to offer and that there's so much value in that as an end in and of itself. And if we just explain it to people well enough, they'll be like, oh, great, I want that. I want that thing you have to offer, as opposed to understanding that, when we do things like that, we're requiring people to assume an identity. Let's say trauma survivor, that actually puts their life at risk in many ways. Loss of family, loss of income, that kind of stigmatization.
And even bullying, because consider being in an underserved community where there's a lot of gang violence in the area. You, as a shield, you have to look tough and basically have a facade of that no matter what happens, you can suck it up and do what you got to do.
Right.
Someone finds out that you are seeing a therapist because of depression, you're going to be targeted. It's like a bully on a playground. They find out that you're the one who's going to cry the most when you get beat up. So
Right.
guess what? You're going to get beat up more because you are going to be a target because you are looked at as weak. So they target you. In our communities, mental health labels I can say dangerous, because if a person perceives you as mentally weak because you're receiving mental health services, you're going to be not just mocked or made fun of. It's very likely they're going to continue to terrorize you.
Targeted, and it's
because
dangerous.
yeah, you're gonna be weak. So that you're the weak one. What you can't says you can't take it. You can't says you can't man up or whatever they tell you. This is what people have to endure if they choose to receive mental health services. If they do, they make sure no one else knows because it's dangerous to them. I think you had a story about the military. Could you share the story about the military, that no one would talk about mental health?
I mean, the interesting thing for me, my limited experience working with Marines in particular is so I had a chance to go to North Carolina, Camp Lejeune, Marine Base, Camp Lejeune, and I got to go into their world, which was like two things happened. The Marines that were diagnosed with PTSD at the time were ostracized from their Marine community. So I could see what you're saying happen in real time. They were on a medical platoon. They were outside of their normal process. And there was an ostracization there that was absolutely clear. And since I got to go into their world, we could establish a place where we could do this, mental health care, embodied mental health care work, because there was a kind of a safety net, so there was both of those things were happening. I think it was unique. I wonder what it would be like out in the community outside of, let's say, off of a base. There was a safety there in the group that I got to work with, but there was also that dual process of being excluded and labeled. And I'm sure there was danger there for them. Absolutely. Not only that, also to their career. Right. Once you get labeled in a certain way, it can have a real impact on your career.
Yes.
And it's making me think too about your work at the public library, right, in LA County with Indigenous communities. So this conversation about, what it's like to be labeled with any kind of mental health care, any sort of mental health issue at all. Maybe we're really talking a lot, especially about trauma, right? It's got that extra intensity to it in some ways. And then your work with Indigenous communities in LA County. I think one of the things we've talked about is how most of the world, I think it's fair to say, doesn't associate with trauma, right? Or doesn't understand trauma in the way that, say, the Western medical world does. How have you learned through that experience to show up as a trauma care provider, for Indigenous communities, maybe where a language doesn't even have the word trauma?
Thank you for bringing that up, because Here's the thing about trauma. Trauma has been around since humans have been around. We just have a clinical word for experiencing emotional wounds that can have a devastating impact on our lives. So there's always been traumatic experiences. It's about what people choose to, how they call those experiences, what they call them, and how they're choosing to address that. For example, for the Indigenous community in Los Angeles, there's multiple groups from Indigenous communities from other countries. Trauma is, there's no translation for trauma in their language, because if a person is wounded emotionally, they're wounded as a whole.
Yeah.
You're going to treat the person as a whole, as someone who has been wounded. So whatever you provide in regards to services have to speak on the levels of mental, physical, spiritual. When you do that, you are basically speaking from the idea that when something traumatic happens with someone, it happens to all parts of them. There's no separation. For the Indigenous communities that are, for the Native American communities that are in Los Angeles, their word for trauma is soul wound, S-O-U-L, wound. You're going to treat the soul wound according to whatever the community says is a treatment that's viable, such as being in community. You're going to have music. You're going to have prayers. You're going to have different types of foods and herbs and spices and drinks, such as teas, to help the soul heal. And it's interesting because all this time we've been thinking, or we've been made to think, oh, those things like using music and art and exercise and dance, all these things are not a part of modern medicine. Those are things that are traditional practices. Have any of you ever heard of medical arts and humanities? And I'm throwing this out there because medical arts and humanities basically states that art and music and dance and everything that makes up a person's culture has evidence-based medicinal value for treatment and healing. That's coming out of Stanford, who has a whole program called Medicine and the Muse, M-U-S-E. They treat their patients with music, art, dance, literature, poetry, you name it. And it's interesting because they've had this program for many, many years. Yet we do not get to enjoy those types of tools or methodologies or modalities because those ideas have never been shared. The evidence is there that things that people from various cultures use to help themselves mentally cope, they're actually viable modalities based in evidence. So what we would like to see for our communities and provide for them that's culturally focused and relevant, we can use them. We just didn't know that we could use them from an evidence-based modality research perspective.
Yeah, right. I just put the link
So
in there.
that's, thank you. But that's the thing when we're talking about trauma and people in general. Trauma is a recent word for a condition, a human condition that has always existed since humans have existed. It's our job to find out how a person defines trauma or a community or culture, and find out what have they developed to address the trauma. Because if cultures didn't find ways to address trauma and all of the negative fallout, none of us would exist.
Right.
We would have been extinct a long time ago. You know what I mean? So yeah. It's just, it's about humility and humanity. What is the person in front of you having to deal with? How are they defining it? And what tools have they been introduced to from their culture or community that is what is, I want to say, viable and successful for treating whatever they're calling trauma, and finding a way to incorporate it into what we call as modern medicine or model or modern mental health practices. All the tools that we need to do what we would like to do are there. It's just we don't get the memos from the research that's being done.
Yeah.
And that's part of my job as well, getting the research so I can use these additional tools.
Breaking down the barriers. That's how the silo kind of works in that space too sometimes, right?
Do we want to start to answering some of the questions in chat?
Yeah.
I think we have 10 minutes left.
There's a good interesting thing here, someone bringing up the idea of the providers themselves. So in taking a look at how trauma can manifest in our healthcare workforce and providers in general, and the stigma that can result in someone who cares for others but is also suffering. And the question really, how do you, in your experience or, in this conversation, how can we better identify and serve those who care for others? What is it, what is that like to incorporate sort of the holistic, everybody that's involved?
I'm very happy for Ryan asking that question, because caregivers are invisible. As long as the caregiver is able to provide care, no one sees them. It's when they're not able to, and everybody else has to deal with providing care, that everybody notices the caregiver because they're not doing what they would like them to do. Caregivers suffer in silence, yes, but it's also important that we build into our assessment when we're assessing, and that's the other part of healthcare, depending on what health organization or clinic or healthcare center I'm working with. Some build into their assessment questions about the caregiver, because the caregiver is just as important as the patient, because the patient is not going to get what they need unless the caregiver, someone takes care of the caregiver.
Yeah. Right.
And it's also very lonely and traumatizing for the caregiver, because no one thinks of their needs until there's something goes very, very wrong with their health.
Right.
So it's important that when we're looking at people who are in need of care, we're also asking who's helping you take care of yourself. And can we see that person as well and include them in the conversation? Because if we want people to be well, there's not just the patient or the client, it's everybody who's associated with them, who might be caring for them, that we also have to support.
Yeah.
And that's where the language comes in. Well, let's provide some additional supports for you and either your family member or your caregiver. And the words I use, support, not mental health, not trauma, whatever word that we're using for that particular center. It's what supports can I provide for you? Tell me what's going on in your life. Let's see what we can do to help you, because we want to support you. And that always is an open door, because there's no label to that. There's no, I'm not giving a person, hanging anything on a person that makes them feel like I'm judging them. You're saying you need help, or you told me a circumstance that sounds very overwhelming. What can I do to support you? How can I help you? And that's what people want to hear most. How can I help you? That praise should be offered along the lines of the people who are in the circle or the network of the person who needs, like the patient, all the surrounding people of that patient or the client. Because we forget, when someone we love is suffering, we suffer along with them.
Right.
And we are experiencing maybe a different kind of trauma, we're not experiencing their trauma, but it's impacting us. Secondary trauma, stress.
Right. Yeah.
It's real. So thank you for saying that.
Yeah, absolutely. It's making me think too. One of the things we've learned in our experience over the years is, well, first of all, right, to name that we live in a very binary society where there is the assumption that there's a sick person or a person with a problem, and then a person that's completely outside of that, who's let's say completely well, you know, who's there to just provide care. And you know, just thinking about what you're saying here, that's unrealistic, and especially with complex trauma, probably unhealthy to just try to reinforce that binary. So we've been exploring the idea that providing care can also be a reciprocal process. And that's really challenging and interesting, right? Because still boundaries, there's still clarity in the relationship, but there may be the possibility of engaging in practice. And I'm thinking about Indigenous practice that I'm aware of, and some of the things you're talking about here, where everybody is involved, like the whole system can be thought of as being, as sort of participating in healing.
Yes.
It's very different than like, there's a broken person that I have to fix. You know, I get to stay outside of that, and it's really not true, but we reinforce that, you know, that it's sort of like, I have to be well in order for this thing to work, or perfectly well. So just even challenging that a little bit. So again, we have a few more minutes. Feel free, folks, if you like. There's another point here around, you know, the dynamics of trauma, encompassing all kinds of interpersonal experience in our relationships. Absolutely. And, you know, we've been talking about some of them, right? Like some of the examples you've named are parent and child, you know, what's happening in our homes, in our intimate spaces. And we know that those spaces are so personal and sacred in a sense, right? But there's spaces where trauma is intruding, right? That's normal. That is how these dynamics work. And so when we're providing care for folks, you know, there's that temptation, like I'm in an office, or I'm in an emergency room, or I'm, you know, on a military base, kind of in a way outside of those intimate spaces. But we're all going back to those spaces. So yeah, we need to find a way to give people opportunities for taking with them. I mean, with what they're learning, sometimes stepping out of some of those dynamics and learning, engaging in healing. Is that possible to take that back with me to my community? I just think there's a lot of complexity there because of that, the intimate nature of trauma.
Yes. I think we have to look at trauma from various lenses. It has to be an interdisciplinary approach to what we call trauma, because it's not just mental health, it's not just physical health, it's socioeconomic, it's environmental, it's everything all at once. So only taking one view and trying to solve it from that one view will always be ineffective. And that's pretty much what I've experienced. When you take only one view or perspective from one discipline, like either mental health or physical health, you're missing all the other pieces. I think we have to be open to the idea of learning what the other pieces are, and being able to either talk to people that represent those other aspects, or learn it enough so we can have some tools so we can actually incorporate those other pieces while we're looking at how to best support the people who need the most support. It's about humility. We don't know everything. And I think that's the thing. It's when we go in to help anyone, our job is to basically find out as much information as we can and learn as much as we can so we can be a service to that person, and be humble enough to know that you don't go in and say, okay, I read this on your chart. This is what you need to do.
Right. Right.
Life doesn't work that way. It's like we have to become a student of what's going on so we can be of assistance.
Yeah, that's great.
Great.
Great. Well, I mean, with that, our time is running down. Desmonette, thanks. That was fun. I hope that was fun for everybody. Where our conversations will continue as we keep moving forward together here, collaborating and just, yeah, that encouragement to everybody. I think that's a great way to end and think about where are those opportunities for collaborating. Humility is very potent and it's not easy. I don't want to pretend that it's easy to say, oh, I've worked so hard on this thing, but that is not the answer in and of itself, right?
Exactly.
It has to be part of something bigger. So how do we keep looking for those bridges and connecting?
So thank you so much for having me today. I appreciate it. Thank you.
Great to talk to you. Thanks everybody for being here and have a good rest of your day.
Thank you. Take care, everyone.
Bye.
Bye-bye.